Hi everyone, it's Adam Ferrier talking again. In this presentation I want to touch on a bit of revision and talk about what exactly is health. Before I begin, I would like to acknowledge the Wurundjeri people of the Kulin Nation, their leaders and elders both past and present, the traditional custodian upon whose lands La Trobe University is situated. This is extracted from a larger presentation in which I talk about the Australian healthcare system, but the objective of this short presentation is to renew and review your understanding of the definitions of health. So I really want to keep the presentation brief. Having said that, I was only exposed to much of what is explained in this presentation when I was completing doctoral studies, and I really wish somebody had pointed this out to me earlier. I certainly would have been a better clinician. So let's dive in. What is health? Often when asked about health, people find it difficult to describe. Now, it's easy to describe what being sick feels like, but often we talk about not being sick when we refer to health. Health is a little like privilege. We're often unaware of it when we have it. Now, most lay people will describe health in terms of what it isn't, and the World Health Organisation's definition is not much better. Some other organisations have tried to address health in terms of human rights, such as that offered by the People's Health Movement. Once again, this tends to skirt around the issue. What actually is health? And the best definition I've ever heard about was introduced to me by Professor Evelyn de Boer when I was doing a policy subject for my doctorate. And she told me about the definition of René Dubos. Now, Dubos recognised the profound interface between the individual and social health and defined health as being the expression of the extent to which the individual and the social body maintain in readiness the resources required to meet the exigencies of the future. So let's unpack this a little bit. So that Dubos suggests it's a quotient between the individual, the interaction between the individual and the community, and it's dependent upon both the individual and the community, not in isolation. But these partners have to do something. It's both preparatory and future-looking. And the problem by building these resources, it may not have an immediate payoff. So it also means the resources personal, physical, mental and social. And the reason for this is that the future is uncertain. Now, you might not have heard about René Dubos before, but I'm sure you've probably heard about another one of his slogans, which is attributed to him, which is think globally, act locally. So if you want to make global changes, you have to make changes in your own backyard. Now, if we look at what the determinants of health, when we first think about health, we tend to consider the person ourselves, which is a perfectly valid starting point. Many of us have a clinical background and we're trained to provide health interventions. So when we think about health, we think of terms of the individual's characteristics, such as his or her genetic endowment, their gender, socioeconomic status, the degree to which they have the control over their lives, their ethnicity, their sexual identity, their physical abilities, their opportunities they've had to develop themselves, their age, and their location and where they live. All of these are personal determinants. But let's look at some social determinants of health. And health is very dependent upon the physical environment in which we may be located. And we may have to consider such factors as environmental factors, geographical location, and the broad features of a given society. So in terms of geographical location, where we live on the globe, the latitude, whether we're close to the poles or close to the equator, will have an effect on the health of a population, as will the proximity to the coast. People that live in coastal regions, well, human settlements tend to be in coastal regions. We also know that people that live in remote areas have lower health outcomes. Taking that step further, the environmental factors of where we live affect our health. The natural characteristics, how bountiful the environment is, whether it's a fertile area or whether it's subject to flood or disasters, and also the degree to which there's development by humans. These two factors will then shape the broad features of a given society, which in turn will influence the culture, the affluence, the general affluence of the society, the social cohesion that exists, whether people get on together, the degree of social inclusion, to what extent there are marginalised groups within that society, the way that they communicate with each other, their media, and whether they have access to a common language. All these factors then in turn will influence the social characteristics, socioeconomic characteristics, social roles and expectations, and the knowledge, attitudes and beliefs of the population. So if we look at socioeconomic characteristics, we have issues such as the degree of education that's available to the population, the amount of employment, whether everybody is able to find employment or not, which in turn affects the income and wealth that might occur, the family structures, whether people have to be absentee parents to go away, whether fathers in some societies have to travel and live remotely from their families to provide an income for the families. We look at things like the neighbourhood, whether there are amenities in the neighbourhood, access to services, housing, the quality of the housing, and food security, whether people can actually access food and in a reliable form, or whether there are forms of famine that go on. These in shape social roles and expectations, and we know that in most societies that there are roles associated or assigned to the different genders, and the roles and expectations will differ for the partners and spouse. If you happen to be a partner or spouse, whether you're a parent will have different expectations, whether you're a carer, the differences if you're an employee as opposed to an unemployed person, or an employee as opposed to a manager, the roles and expectations of a friend, and there are other ones as well. Coupled with this are the knowledge, attitudes and beliefs, and this can be expressed in terms of health literacy, how literate is the population, their degree of trust in the medical profession and their trust in medicines, and also their faith in alternative medicines. These in turn will influence health behaviours, and psychological factors and safety factors. So let's look at these, unpack these a little. Psychological factors that may occur in a population often refer to the degree of stress that occurs just by living in the population, the degree of trauma that might be experienced there, or torture, which is a strange thing to us in Western societies, but in other societies there are sometimes unfair practices where people can be unfairly treated. The degree of rioting or conflict that occurs, and exposure to warfare. This will have an effect on the safety factors, which will involve, may be expressed by the risk-taking behaviours, the degree of violence that occurs in a given society, the degree to which there are occupational health and safety measures and regulations to counter this, road safety and compliance with road rules to avoid road trauma, and agreed standards of behaviour, agreed standards for things like building and provision of food, food safety, issues like that. These in turn have a direct effect on the health behaviours of individuals within the population, and these can be expressed in terms of tobacco use, alcohol consumption, the degree of physical activity that a population may have, dietary behaviours, the degree of illicit drug use, sexual practices, and vaccination rates. This then in turn takes us into the factors that we're used to as health clinicians, the biomedical factors, and things that we can measure, such as birth weight, body weight, blood pressure, blood glucose, glucose tolerance, and immunity status. These things then have an effect on our health and well-being over time, which we can measure as terms of life expectancy, mortality rates, the people's subjective feelings of health, how they self-rate themselves or their health, their functionality, disability rates, the rates of acute illness, the rates of chronic disease, and the incidence of injury. So when all these are put together, we have the personal, physical and psychological makeup coupled with the social determinants of health, and then we will often have government responses such as policies, strategies and interventions to counter these issues, the prevention of diseases and health promotion, early intervention measures, rehabilitation and palliation, and all these require resources, systems and research to provide evidence-based care. Now, it's okay if you're feeling that I'm going at this at a rate of knots, I perhaps am, and I apologise for this, but how is this expressed? Well, I want to explain why Australia in particular, the delivery of health services are a persistent political issue for our governments. Health outcomes are political outcomes. Basically, health is a human need. It is also a commodity because health services can be bought or sold, therefore it has market value. If we consider health in terms of a market, consumer aspirations become apparent. The desires and preferences of how health is consumed can be identified and, to the more cynical of like myself, shaped. This is a fundamental problem that the United States and to a lesser extent China faces. These desires and aspirations might be highly influenced by existing beliefs, be they party political, philosophical or even religious. And health systems do not suddenly appear, they have developed over time. We often speak about our health system being in a constant state of reform to meet changing needs. And the provision of health, or any other aspect of society for that matter, will be influenced by the dominant customs and traditions that are valued by the population. And sadly for you, these are often competing demands, especially if to meet one particular set of constraints is at odds with another factor. For example, in the United States, the birth control is definitely a need, want and desire or preference for a large proportion of the society, but often at variance with the customs, tradition and beliefs of the vocal minority of the population. So this often prevents federal government programs from funding birth control. So health outcomes are political outcomes, and the role of politics is to achieve concord out of chaos. And that really is what politics is about. And the outcome of this is expressed through policies. Policies are generally defined in terms of regulation and funding, which gives rise to the structure of a health service. And this can be both the physical facilities and the human resources that are provided within the organisation. This in turn affects the function. And the function are measured in our health system by outputs. Outputs are often quantitative in nature, the things that we can count, but outcomes are more generally long-term and qualitative in nature. And in the previous slides, I've expressed this as a cascading process, but in reality, it's a process, a repeating process that goes around in circles. And when you add the two together, of the needs, wants, desires or preferences, beliefs, existing or available resources, customs and traditions, together with the outcomes, the concord that needs to be released or achieved, the policy that results, the structure which affects the structure, which affects the function and the outcomes, we simply do not live in an easy world, no matter what political structure exists. This really explains why politicians, in this country in particular, talk about there being a need for constant reform of systems. There are a number of different financing models. In our country, in Australia, the majority of funding for health provision comes from the government through a single or unitary provider, and it's expressed in terms of recurrent expenditure, which is for the function of the system through the consumption of resources, and capital expenditure to build physical facilities. Now, a little word about funding is in 2013 to 14, which is the most recent reliable figures that I could find easily, Australia spent approximately 1.5 billion on health. And let's say this was spread amongst 24 million people, which works out to be about $6,500 each. There's a big difference between equality and equity. Dividing up a limited resource and distributing the quotient equally may seem fair, particularly to accountants, but often populations have differing needs. It's the same with health. Now, there are things associated with health promotion that can be shared equally to benefit communities, such as clean air free from pollution, clean water without disease, and eradication or control of vectors such as vermin, effective garbage collection and disposal of sewage. But health services that are remedial cannot be shared equally because remedial health needs arise in a space-time context. Unless an individual has a chronic condition, the average person consumes relatively little health resources during their adult life. It's usually at the start of life and towards the end of life that significant health resources are consumed. So in any particular year, it would not be appropriate to spread this out equally to people, $6,500 each. It just really wouldn't work. Now, moving on quickly to quality of healthcare, talks about what the outcomes are achieving from the structure and the functioning of the health services, and continually striving to ensure that we're doing the best things possible for our clients. And the changes to this need to be achieved through strategic organisation. This is why in the MHA course in particular, we cover such areas such as strategic management, quality management and health financing, so that we are very clear about how this affects the outcomes for our population. So in this very brief, and this is supposed to be a review to help you remember these issues, we've reviewed some definitions of health, the social determinants associated with health, the personal determinants of health, that health outcomes are political outcomes, and that politics is creating concord or agreement out of chaos. And we've looked at the association of strategy, financing and quality management to health outcomes. Yes, it has been whirlwind, but I've tried to keep it brief. Happy to take questions, or if you like to discuss any aspect of this with me, please touch base with me. Look forward to hearing from you. Bye.